Hi, my name is Mariam Derogar. I'm a medical doctor at the Karolinska University Hospital and PhD student at Karolinska Institutet in Stockholm, Sweden. I've been asked by the editors of Clinical Gastroenterology and Hepatology to present a recently published study entitled Aspirin Therapy Discontinuation After Peptic Ulcer Bleeding Increases Risk of Death and Acute Cardiovascular Events. As we know, aspirin is widely used in the prevention of acute cardiovascular events. However, it also carries a risk of gastrointestinal bleeding. So in the setting of peptic ulcer bleeding, it's a great clinical dilemma whether aspirin therapy should be discontinued or continued. Therefore, we decided to perform a retrospective study on all patients with ongoing aspirin therapy who were hospitalized due to peptic ulcer bleeding at the Karolinska University Hospital between 2007 and 2010, and patients were followed up until August 2011. We included patients who were admitted to hospital due to symptoms of upper gastrointestinal bleeding, that is melena, hematemesis, syncope, presyncope with anemia, or of course the combination of these symptoms. And patients were also diagnosed with peptic ulcer by verified by endoscopic examination. We also collected information on patient and disease-related factors that could have affected the clinician's decision to continue or discontinue aspirin therapy. And these were, for example, comorbidities and forest classification. We performed survival analyses and divided the follow-up period into before 6 months, after discharge, and after 6 months. In total, we identified 118 patients with ongoing aspirin therapy who were hospitalized due to peptic ulcer bleeding. And aspirin therapy was discontinued in 40% of these patients. The median follow-up time was 2 years, and during this period, 37% of patients developed acute cardiovascular events or died. In the multivariable analysis, we found that in patients with cardiovascular diseases, there was a 7-fold increased risk of death or acute cardiovascular events in those who discontinued aspirin therapy at discharge compared to those who continued aspirin therapy. And importantly, this finding was only evident within 6 months of discharge and not thereafter. Recurrent bleeding was observed among 7 patients at a median time of 20 days. 3 of these patients had continued aspirin therapy and 4 had discontinued aspirin therapy. Due to the small numbers, we couldn't perform any statistical analysis to examine the association between aspirin therapy discontinuation and the risk of recurrent bleeding. In conclusion, this study provides evidence that aspirin therapy should not be discontinued after an episode of peptic ulcer bleeding. What we don't know is the optimal timing to resume aspirin therapy, and this should be clarified in future studies. Thank you.